Can I invite Dr. Saumil SHETH to present his talk on nucleus drop? Dr. Saumil is, of course, have you loaded your presentation?
Yep. So my presentation is about dropping the bomb. Whenever you don't follow what Dr. Ashok just mentioned and you land up with a PC rent and a nucleus drop, how to manage that? I'm going to be presenting a lot of unusual cases about managing nucleus drop. And I would say it takes a lot of courage for so many people to turn up on a Sunday morning at 8 o'clock after having partied Saturday night. So thank you for the audience. Now this is a case that was referred to me by an anterior segment surgeon saying, I have done everything. All you need to do is anterior vitrectomy and put in the lens. There is no capsular support, so I did exactly that. I put an iris claw lens, posterior or retrofixation behind the iris, and it's got done well. Now, when I was trying to do that anterior vitrectomy, I just took a peek inside, and this is what I noticed. The anterior surgeon will never tell you that he's dropped a piece or two. Now, how do you remove that piece despite the iris claw being there? So what you do is I impaled it in a 26 gauge needle, and between the pupillary border and the border of the iris claw lens, I tried to bring it out into the anterior chamber. I could have taken a fragmentome and done it inside the vitreous, but then I would have had to take a suture. The patient was told, by sutureless, you have to do it. So this is what I did. And the advantage of doing this maneuver is that you have a scaffold of iris claw lens, and now you can phaco very well in the anterior chamber without the risk of any piece dropping into the vitreous cavity. You see there are so many fragments that come into the anterior chamber. They move around in the anterior chamber and they don't drop into the vitreous cavity. So you can perform your phaco very successfully as like how you would have a posterior capsule in the first place. And so the phaco is done, and then you're left with no lens matter in the vitreous and the surgery is done. In this case, I'll just pause here. The surgeon has dropped both the nucleus as well as the IOL. Now what does common sense tell you? That yes, you need to manage the nucleus first and then lift the IOL. I did exactly the opposite. I lifted the IOL first. Why did I do that? Because I learned from my previous example. I removed this IOL out into the anterior chamber and then retrofixated it behind the iris in the same way as I did in the previous case. So I put an iris claw there, and I knew very well how to manage the nucleus, like what I did in the previous case. I impaled it with I took it away from the macula, impaled it so that there is no pressure on the macula of the nucleus, and exactly this is what I did. I took it out between the iris claw border and the pupillary border into the anterior chamber. There were a couple of small fragments of the cortical matter that has got dislocated into the vitreous, but that you can easily manage with a cutter. You don't need really a fragmentome. This is where you would have used a fragmentome otherwise. Here you use a normal phaco probe, and the other pieces can easily be managed. These are just epinuclear or cortical remnants which would have easily come off with the cutter. So this is one of the ways by which you can manage a nucleus drop if you have an IOL scaffold by not actually going with a fragmentome into the vitreous. Now this case, just look at this case. This is a case of a multifocal lens. The surgeon has implanted into the sulcus and the lens is decentered. And there is a lot of cortex behind. This patient, despite having multifocality, is not going to see well because first of all, the lens is decentered. Secondly, the lens is in the sulcus. The patient is going to have a major refractive error. So in this case, the way you manage this is, yes, obviously you need to go behind and remove the cortical matter, but that would only tackle the anterior vitreous and the cortical matter. What do you really do of the IOL? Should you explant it and then put a 3-piece lens in the sulcus? So what I noticed is that there is a PC rent which is right across, and there is enough of capsular support for me to go. So what I did is this is a maneuver again that I do, which is not very commonly done. Put a light pipe and check the vitreous cavity. This light pipe is put from the anterior port, not from a pars plana port. And then I try to put the lens in between the anterior and the posterior capsule. And this you have to do in a bimanual way. You cannot just put it easily. You have to lift the anterior capsule with one instrument, and with a forceps, the intravitreal forceps that we commonly use, you put it in between the capsule. And that's how you get the lens in the bag. I don't know why this video just stopped. So I'll probably see so there it goes into the bag. You see a crumpled bit of the posterior capsule here, and it falls back in place, comes when the lens is nicely settled into the bag. I'll go on to the next case. This was a case that I presented previously. And this is a little bit of outside the box kind of a thinking. Now you see this is an open and shut case. The surgeon has actually put the lens in the sulcus and has referred the patient to me to manage the cortical matter behind the lens. All you need to do is just a little bit of anterior vitrectomy, do away with the cortex, and that's it, open and shut case. Now why am I actually presenting this despite it being so, is because let's say I started doing anterior vitrectomy here, and when I was doing anterior vitrectomy, as the vitreous started clearing and the view started becoming better, I realized that it was not a PC rent. It was actually a zonular dialysis from this claw cover to this claw cover. And the bag was fully intact. So the cortex was not actually in the vitreous. It was in the bag per se. So I really don't need to do a vitrectomy. So what I did is first inflated the bag with viscoelastic. And this is a little bit of acrobatics that I did. Put in a CTR behind the IOL into the capsular bag and inflated the bag. And once the bag is inflated and all the vitreous is pushed behind, I don't really need to do a vitrectomy. Though I took a vitrectomy probe, I just went behind the IOL, put in an AC maintainer first, and just aspirated the lens matter without cutting it. The bevel is facing me, it is not facing down. Otherwise, it would now create an iatrogenic posterior capsular rent. Now, having done that, the lens is very well sitting in the sulcus, but I now needn't put it in the sulcus at all. I can actually put it inside the bag, and that is what I did. And that is how this was managed. The patient didn't have to undergo IOL explantation with a 3-piece implantation. I could manage with a 1-piece lens because I put it actually in the bag. Now this is not all. You can get away with doing this. You don't really need to stop at this. Despite having just a zonular dialysis, no vitreous in the anterior chamber, I still went posteriorly to complete my vitrectomy. And this is the reason why. Because if you have a PVD that is induced by an eventful cataract surgery, this is what you would have landed up in the late postoperative phase. You would have had an iatrogenic break. You see a break actually developing when I'm trying to tackle the vitreous in the posterior chamber. This would have happened naturally as a result of PVD later on, and the patient would have landed up with a detachment. So you would have had to keep the patient on a very close follow-up postoperatively to see for retinal tears, but much easier to manage posterior vitreous, especially if you are a VR surgeon in the same setting itself. Now in this case, again, this is a case of surgical aphakia, and there is some vitreous in the AC, and I was told to put in the lens. And 1 second. Okay, so this is a slightly, again, a little out of the box kind of a thinking, wherein I did do an anterior vitrectomy. I made in 3 ports. I did a triamcinolone staining of the anterior vitreous, tried to push as much of vitreous back into the vitreous cavity.
And again, even lifting.
Okay, by sort of removing those strands that have gone to the wound, lifted the iris skirt as well, and tried to remove every little strand of vitreous. Now this is what I did unusual. Instead of doing 3-port pars plana vitrectomy, I did a 3-port limbal vitrectomy. I made all the 3 ports at the limbus, put in the light pipe. You can actually do this maneuver even under topical anesthesia. Because you're not making pars plana scleral ports, you can get away with even managing posterior dislocation of the lens through limbal ports. So I call this procedure as PPV only, but it's not pars plana vitrectomy, it's called portless posterior vitrectomy, wherein you make all the 3 ports at the limbus and not through the pars plana. And this is the final stage where I put an iris claw lens. Now this iris claw, this is a usual way of implanting an iris claw, but you see the amount of turbulence it creates because there is an open wound and you're going through the main wound. Now this is again an alternative maneuver where you go through the side port with an intravitreal forceps and you enclave one haptic with into the iris, and then you go from the other side port with the same intravitreal forceps, and then you enclave the other optic. So this is another way of probably retrofixating an iris claw lens. This is a very handy lens which is manufactured here by Appasamy in cases when you have surgical aphakia and the iris support is not good to put an iris claw lens. There's a type of a scleral fixated lens where you do not really need to use a suture. You use a foldable lens, you put it into the anterior vitreous, bring the haptic out. These are hydrophilic haptics and they stay very well outside the sclera under the flap without any risk of extrusion or irritation, because they are essentially hydrophilic in material as against proline, which we usually use in scleral fixated lenses. So here the hydrophilic material, again the other haptic being brought out through a slit incision which is done exactly perpendicular to the orientation of the haptic, and there you put the haptic under the flap, and that's about it, and you get the surgery done very quickly. So these were some of the unusual cases which I thought I should share with you guys. Thank you for a patient listening.
Thank you, Saumil. So it's always such a learning experience for me as well to watch your videos. And anyone has any questions?
It's notorious for making CME, isn't it? Nucleus disruption already there. They're pulling the iris, so conjunctival anticipation. So overall, what will be the CME percentage, sir?
So the typical CME occurs when the vitreous interacts with the iris tissue, and that causes that irritation. Every strand of the vitreous that you not only find in the anterior chamber needs to be removed, but the vitreous that is even going from behind the iris and sticking onto the posterior surface of the iris also needs to be cleared. So that's why I always lift the iris up and try to remove, like it's like a skirt. You just lift it and you try to remove the posterior vitreous from behind the iris. But I usually don't stop at that. I also go and do a total posterior vitrectomy because I'm not worried that much about the risk of CME. I'm more worried about the risk of peripheral tears and detachment in the late post-operative period. So I do a posterior vitrectomy, and I showed you one maneuver by which it's not necessary to go pars plana. You're doing cataract surgery under topical anesthesia, you can keep that topical anesthesia going on, and you make those limbal ports and you enter through the limbus into the vitreous cavity, and you can do a neat enough posterior vitrectomy there.
Saumil, how important is it to do a complete vitrectomy in these cases?
See, wherever you have access, I feel it is an absolute must. If you are a VR surgeon and you are managing such a complication, you definitely have to do it, is what my thinking is. It does not take more than another 7 to 10 minutes to tackle a posterior vitreous, but goes a long way in preventing a huge number of complications later on. But if you are in an anterior segment setup and you are managing a posterior PC rent and you do not have access to a posterior vitrectomy, it's good enough to do an anterior vitrectomy and put the lens in the sulcus, but then refer the patient at least to a VR surgeon on a regular basis so as to see the periphery. In the first 6 months is usually when this PVD occurs and you get this risk of late post-operative tears, and that is when they need to be tackled by a barrage laser or something.
And your advice once a rent happens, what is your advice to anterior segment surgeons? How to go ahead? Should they put a sulcus lens or should they put iris claw lens? I think the most important thing is to clear the anterior chamber from all the vitreous which is there.
Correct. So that is the takeaway point. The lens is an optional thing. You can put a sulcus lens if the sulcus is adequate, and I would advise to always go for a 3-piece lens because it does not cause that retro iris irritation. But even if you don't have access to a single piece, a 3-piece lens, a single piece lens is good as long as it has very fine haptics and it is hydrophobic in nature, which is usually the kind of lenses that you find. Hydrophilic lenses usually have very stout haptics, and they are the ones that cause a lot of retro iris irritation, and they cause late onset UGH and things like that. So I would not advise that.
No. So hydrophilic lenses are more UV friendly. So if you at all have to put a sulcus lens in the sulcus, it has to be hydrophilic.
So it's not about the material per se.
No,
when I said it's about the thickness of the haptic.
Thickness of the haptic is more in hydrophobic lenses than hydrophilic. So
the present day hydrophilic lenses that we use, they have that hole in the haptic and they have a double haptic around, like the typical Rayner and the Ultima design that we are talking about.
Less.
Okay. So my experience has been reverse, but point well taken.
And
So
always put a suture.
So Saumil,
Yes.
Correct. Under ideal circumstances, it should be a 3-piece. But if you are an anterior segment surgeon and you don't have something handy,
so considering the cases that you had shown, where the first surgeon sent the patient to you, the anterior segment surgeon sent it to you saying that there's sirf lens dalna hai, and you found a nucleus in the back. So would you advise such patients, surgeons to implant an IOL in such a situation, or is it better to keep a patient faking and refer them to a retina surgeon?
So it's all about the perception. I would always advise the anterior segment surgeon to put in a lens, because he also has to get away clean in terms of an outcome given to the patient. And the patient has this fixation in his mind that lens to dalna hai. So from somewhere, if you put a lens, you manage your surgery successfully. If we have a very dense nucleus like the kind I showed, you can use a fragmentome and you can use a suture, you can do a pars plana vitrectomy, that's all right. But I feel if a lens is put by an anterior segment surgeon, as long as it's a 3-piece lens, it is all right, in my opinion.
So just another question, if a single piece IOL is already placed by an anterior segment surgeon and then in the sulcus, then would you prefer explanting it, or would you just...
So very, very good question. I would rather leave it because the work has already been done. If I feel that the patient has a lot of CME and late onset UGH and I have cleared the vitreous very nicely, then it is only because of the lens, and you'll also see it on the UBM, in which case I'll explant and then exchange it at a later procedure.
Okay.
I won't touch it there and then.
At that point.
Yes.
Usually, if you do a complete vitrectomy, the lens falls back, so there's an adequate
Yes.
gap. It doesn't
Yeah.
retain.
Yes, I've seen that. Yes.
That happens.
That's a very good point actually
Yeah.
brought out by sir. It's a hyped thing. It's actually the vitreous that is a culprit, and if you've cleared it really well, even from behind the iris, you usually get away with